case 1. You can take this case.
I'm presented with DP and oblique views of the hand in a skeletally mature patient. On first review, I note that there's abnormality in the proximal interphalangeal joint of the little finger. On the oblique view, there's also some abnormality of the thumb carpal metacarpal joint. So just focusing more on the little finger of the hand, there's loss of joint space, and it looks like there's also some surrounding osteophytes formation. There's also loss of joint space in the distal interphalangeal joints of the middle finger, ring finger, and the little finger. And the deformity of the thumb appears to be degenerative. So I think this patient is likely to have osteoarthritis, but I'd like to compare with any old imaging to see whether these findings are acute. And I'd also like to know how the patient has presented with their clinical presentation.
Okay. Where do you think the pathology is focused predominantly? Which joint space?
Within the interphalangeal joints, and predominantly the proximal interphalangeal joints of the little finger.
Okay, so your primary diagnosis is?
I think this is osteoarthritis.
Okay, what are the differentials?
So in terms of differentials, this could be an inflammatory arthropathy, such as rheumatoid arthritis. In this case,
Okay.
I'd expect to see ulnar subluxation of the fingers.
Okay.
And I'd also expect to see erosions, which I can't see on these images although I would zoom in normally in my normal practice to review the joints more closely. And generally, the bones don't look osteopenic, so I'd expect this with an inflammatory arthropathy. Other disease processes which are polyarticular include gout, but I'd expect to see a gouty tophus or psoriatic arthropathy, in which case I'd expect to see some new bone formation and dactylitis, but I don't see any soft tissue swelling on this case.
Okay, yeah, excellent. So this is the description I was actually looking for. Well, I'll just briefly give you some teaching on how do you approach, especially the arthritis cases, if you encounter in the exam. It's very unlikely that you may not get an arthritis case in the exam. So you just stay with me. I'll just want to highlight how do you approach arthritis. So if you already have a set approach, especially for the arthritis cases, so please do follow that. You can probably add on to any of your with your reading. If you are if you are approaching arthritis, if you don't have any set pattern, I would suggest you to follow this. This is an excellent one. So how do I approach an arthritis case? So I'll first look at the articular surface, so especially the joint space, whether there is any narrowing, how is it, how is the cartilage, and then look at the deformity, if there is any swan neck deformity or Heberdine's nodules, and also if there is any destruction, where the destructions are, is it at the distal or at the peripheral. Next is look at the bone, look for any proliferative changes, and also the bone density, which is very important if there is any osteopenia, and also erosions. Then look at the cartilage. Is there any central cartilage loss or at the periphery, or is it the diffuse cartilage loss? And D is for distribution. Look where is it distributed. Is it symmetric or asymmetric? Is it proximal or distal? Is it monoarticular, or is it more than one joints which are involved? And S stands for soft tissue. That includes periarticular, soft tissue, and then fusiform, or is it nodular? So we'll just look at it one by one. So we'll start with the joint space. So if you see a joint space narrowing, if it is symmetric or asymmetric, you have to figure out. And if the erosions are present and if there is a soft tissue swelling, then you have to think about think in terms of inflammatory. And if you go along with inflammatory changes, then you, whether is it less than one joint space involved or more than one joint space. So if it is less than one joint space, think about infection. If it's more than one joint space, think about rheumatoid and also seronegative arthritis. So in rheumatoid, look at all whether where is it involved? Is it proximal or at the distal part? Usually, initial stages of rheumatoid will not have any bony proliferations. As the disease progresses, patient will have bony proliferations. Then patient will also have osteopenic changes, especially in rheumatoid arthritis. And in seronegative, mostly it involves at the distal aspect. There will be a bony proliferation, and other important thing that involves is the enthesitis changes or involvement of tendon inflammation. So if it is at the degenerative pattern, it can be a typical osteoarthritis, and or it can be an atypical one where secondary to post-trauma. Other differentials are crystal deposits, neuropathic, and hemophilia. So these are the classic examples where there is typical articular erosion patterns. So the first onto your left is the erosive osteoarthritis. You will see both medial and lateral condylar osteophytes. So the differential diagnosis or the differentiating feature between the erosive arthritis and the osteoarthritis is look at these central cartilage loss that is very typical for the erosive osteoarthritis, whereas mostly subchondral erosion happens in classic osteoarthritis. And look at the soft tissue pattern, if there is any soft tissue swelling, and then marginal osteophytes with marginal erosions, think of rheumatoid arthritis. And if you see a periarticular tophi or juxta-articular, that is the terminology which is used, think about
Teacher call karo.
And in psoriatic arthritis,
अभी था ना तुम्हारा रेड स्कार्फ, वही पहन लो.
There will be bony proliferations. Can actually appreciate.
Sorry, Sam, I had to mute you. Can you unmute yourself once again?
Okay. Can you hear me, sir?
Yeah, I can hear you.
Okay. So as the disease progresses, you will see this central cartilage loss and osteodestruction with progressive penicillin cup deformity in psoriatic arthritis. So the next one is how whether is it uniform bone loss or non-uniform, or is there any absent joint space destruction? So if there is any absent joint space destruction, then you have to think of a gout where there will be a juxta-articular soft tissue swelling. And in uniform, in uniform joint space narrowing, you have to think of these three important differentials, that is your rheumatoid arthritis, hemophilia, and alkaptonuria. Note, especially the rheumatoid arthritis, early changes will present as uniform joint space loss, but as the disease progresses, at the end stages, there will be severe osteopenia and bone destruction and also joint space narrowing. So if there is a non-uniform joint space narrowing, think of osteoarthritis and crystal deposits. So next is joint deformity. If there is any joint deformity, you have to think of rheumatoid arthritis, SLE, and Charcot's arthropathy. If there is articular destruction, it's very classic for rheumatoid and dermatomyositis and psoriatic arthritis and scleroderma. So these are all some classic examples for joint deformity versus articular destruction. So the next on our list is the bone proliferative changes. So when we talk about bone proliferative changes, you have to see if there is any osteophytes or if there is any periosteal changes. So if you see osteophytes, you think of osteoarthritis, crystal deposits, and hemochromatosis. So the example here is you can nicely see multiple kind of hook-like osteophytes and also joint destruction. So predominantly involving the second and third metacarpal joint, which is a very classic for the crystal deposit disease. So and also look at the ossification or calcifications of the both ulnar and as well as the radial aspect of triangular fibrocartilage ligament complex. So these are all a very classic picture that for crystal deposits, especially the calcium pyrophosphate crystal deposit disease. And similarly, if there is multiple hook-like osteophytes, but not much of calcifications involving the TFCC, but there is not only a predilection for the second and third, it can involve all the metacarpals. So then you have to think of hemochromatosis. Then look at the periosteal changes also. You have to think of psoriatic arthritis, reactive arthritis, ankylosing spondylitis, and inflammatory bowel disease related, and also hyperparathyroidism. So this is an example of psoriatic arthritis where we can actually appreciate nice swelling or very soft tissue swelling, and then joint space narrowing, predominantly involving the distal interphalangeal joint. Then you have to think of a psoriatic arthritis. This similar picture, psoriatic arthritis picture, if you are able to see in the lower extremity, then think of a Reiter's or an inflammatory origin. So Reiter's also will present with joint space narrowing and very soft tissue swelling. So you have to think of a Reiter's disease. So the teaching point, subchondral sclerosis is typically seen in osteoarthritis, neuropathic, and also psoriatic arthritis, but not in rheumatoid. And if you the classic picture that you get to see in psoriatic arthritis is that fluffy periosteal reaction with bone sclerosis. So if you see osteopenic changes, whether is it diffuse, then think of crystal deposit disease. If it is only localized to the periarticular region, then think of rheumatoid and complex regional pain syndrome. So next is we have to classify the types of erosions. So whether is it marginal, then if it is a mouse ear kind of pattern, then think of osteoarthritis first, rheumatoid, and then psoriatic arthritis. And if it's a marginal bone erosion with pencil in a cup, then think of the psoriatic arthritis. So you can actually see this that mouse ear kind of pattern, and you can in psoriatic you can see that pencil in a cup kind of deformity. So if there is a juxta-articular or central gull-wing kind of pattern, then central gull-wing, that is the central gull-wing, that indicates erosive osteoarthritis, and juxta-articular with a soft tissue, nodular swelling, and atophy, think of a gout. And if there is any distal involvement. So if you see a distal involvement, you can actually see this large soft tissue calcification, acroosteolysis. Then you think about scleroderma. If there is a disintegrated bone, so these two important differential fits in, especially the osteomyelitis and collagenopathies. If there is only periarticular erosions, then think of gout and thermal burn injuries. especially involving the distal interphalangeal joint space. And acroosteolysis, or destruction of tip of the bone. So think of psoriatic or hyperparathyroidism, and also in thermal injuries. So then moving on, we can localize the arthritis spectrum based on the distribution pattern. So in rheumatoid, more or less involves the MCP joint. It can also involve the interphalangeal joint. Very rarely it can, or it cannot involve the distal interphalangeal joints. So, and of course, most common along the carpal bones also. So there is, as the disease progresses, there is destruction of the carpal bones, and eventually causes all this ankylosis kind of spectrum. Next is the psoriatic arthritis. So involves predominantly the distal interphalangeal joint, and you can actually appreciate the soft tissue swelling along with BAP joint destruction. In osteoarthritis, so there is not much of a set spectrum, but very classic is at the first MCP joint, and it can involve the proximal and also the distal. So next is the crystal deposit disease. So first, most commonly involve the second and third metacarpal joints with hook-like osteophyte, and also along the TFCC ligament. Gout variable, so it can involve the carpal bones. It can involve the first MCP joint, and also the mid interphalangeal joints. So based on soft tissue swelling, so we classify, is it nodular soft tissue or is it fusiform, or the soft tissue is only at the periarticular region. So if it is a nodular soft tissue swelling, in this case, think about gout. If it is a fusiform fusiform swelling with some DAP involvement, think of psoriatic arthritis. And if it is a periarticular swelling, think about rheumatoid arthritis. So I usually give this is how you should tackle the arthritis cases. So note down the age of the patient, which plays a very important role in finalizing or differentiating the various arthritis spectrum. Then location, is it upper extremity, lower extremity? So this is very important. If you take an example is the psoriasis, so mostly involves the axial and the upper extremity. It rarely goes to the lower extremity. Then look at the distribution. Is it symmetric, asymmetric, or is it more than one joint involved? And joint space narrowing, is it present or absent? Joint deformity, so once it is present, so it is going to lead you towards those destructive arthritis spectrum. Example is the rheumatoid arthritis. Then look at the articular destruction. If it is, then again all the other destructive pattern that includes rheumatoid, psoriatic. So all this will have articular destruction. Erosions, so that we have already talked about. Is it like mouse ear erosions, where the erosions are localized? So based on that, we can classify the arthritis. And finally, soft tissue inflammatory mass, whether it is present or it is absent. All right. Let me, candidate 1, you are still there?
Yes,
I'll just show you. Yes. How do I, yes, okay. So this is your next case. So this is around 30-year-old male with history of fall.
Okay. So I'm presented with anterior posterior and lateral view on the left knee in a 30-year-old male who has come in with a fall. Just assessing first for any fracture. So on the frontal view, I don't see any evidence of a fracture. There's a little bit of sclerosis on the lateral tibial plateau, but I'll also assess on the lateral view. And I'd just like to check, was this taken as a horizontal beam view, or was it taken standing? Because I'm looking for the lipohemarthrosis.
This is just an horizontal beam view. It was not
Okay.
taken during standing.
Okay, I don't see any definite evidence of lipohemarthrosis on this projection. There is a large notch within the femur between the two femoral condyles. And I think this can be a feature secondary to hemophilia. I'd just like to also check whether the patient has any history of known blood clotting disorders.
There is no blood clotting disorder.
Okay.
No history.
Okay. And also on the lateral view, I have noticed in the popliteal fossa, there's a small calcific focus. So that could represent a small bony fragment. Given that the patient is presented with trauma and there's the abnormal appearance of the lateral tibial plateau, I would recommend orthopedics review for this patient. They may wish to proceed to cross-sectional imaging to confirm the findings on the tibial plateau. And I'd also want to check with any previous imaging that the patient has had to see whether the appearance of the femoral condyles is the same on that imaging, or this is a new finding.
Okay. Any other? What is your next step? You will only refer this patient to orthopedic surgeon, and then.
Well, I think it might be useful to have radiographs of the right knee to compare whether this is a symmetrical process or this is focal. And following the orthopedics review, they may wish to organize MRI of the knee to assess for any ligamentous injury. Again, I'm just focusing to see whether there's any evidence of second fracture, but I don't see that. So I think that suggests less likely to be ligamentous, although it's not completely excluded on the basis of the plain film.
Okay. So we have done MR for this patient. I'll just show you the MR also.
So we have two views here. On the left of the screen is a fat-sensitive view. And I think this is showing the anterior cruciate ligament, which has some high signal within it. Just on the second view, this is a fluid-sensitive view, and there's some bone marrow edema within the lateral femoral condyle. I would, in normal practice, scroll through the images to assess the menisci as well. And I'd also want to assess the posterior cruciate ligaments and the lateral. Well, I can see the lateral collateral ligaments, the medial collateral ligaments intact, but the lateral collateral ligaments I can't see on these images. So I'd want to know if any further sequences were obtained for this patient.
I doubt. Let me. No, only this much.
Okay.
We have done. Okay. So what could be
so,
your diagnosis? And
so I think this patient has is likely to have
a giveaway in your in the plain radiograph itself. There is a slight giveaway if you look at it very carefully.
I don't think I've seen findings.
Okay, fine. So yes, so let me get back. So this is nothing but an ACL tear. So you have to look at this femoral notch sign. Have you heard of this femoral notch sign? There. So it's just quite little bit widened or deepened, I would say. So you draw a line from here till here, and then you measure this region. So it should be less than 1.5 mm. So here we got almost like some 1.9 mm, and then we followed this, followed it up with the MR. You can actually see there is some tear in the femoral attachment of the anterior cruciate ligament. And of course, there is some edema and bone bruise along the medial epicondyle of the femur. So just a plain radiograph, the case is just is to show you, you have to be very careful and measure this line, especially on the lateral view. That can give you a clue. All right. Next case.
I'm presented with an OPG, and this looks to be an adult patient. Just firstly, I'm assessing the mandibles on both sides. There looks, I think there's a fracture on the right side of mandibular condyle. I would normally zoom into this area, but I think I can see a disruption in the cortex. Thank you. And if I see one fracture in the mandible, there's often be a second fracture. So I just assessed closely the rest of the mandible. But I don't see any fracture on the right side. And could I please see the left side of the patient?
Yeah.
I don't see a fracture there. The temporomandibular joints are not fully imaged here, but there's no definite evidence of dislocation. So to summarize, I think that there's a right mandibular condyle fracture, and the patient would require referral to the maxillofacial surgeons for treatment.
Mm-hmm. Can you see this periosteal reaction?
Oh yes, the soft tissue.
Yes. So there's a big soft tissue swelling is also there.
Yeah.
So that's that. What is that periosteal reaction called? What is your next step of investigation? What will you do to this patient? So this was a 30-year-old female again, presented with progressive increase in swelling on the right side. So for 3 months, patient had a progressive swelling, and she presented to the OPD.
I think to assess the soft tissues, the patient should have an MRI of this area. A CT may also be useful just to further assess the underlying bone and to see whether there's any bony abnormalities relating to the teeth. And I think there is some element of, well, there's periosteal reactions. There is some element of calcification there. Again, the CT will help to determine the distribution of that.
Okay. I'll come back to this X-ray. I'll explain. So let's that's the CT. We did CT.
Okay, so there's on these coronal images with the bone windows, there's quite diffuse periosteal reaction surrounding the right mandibular ramus. And again, we can see there's a large soft tissue component associated with it. This has aggressive features, the periosteal reaction. So the underlying process, it could be infection, but I'd have to consider malignancy, especially given the slow onset of the symptoms. I'm not completely familiar with the tumors that can arise from the jaw, but because the bone is involved, osteosarcoma should be considered. In my local institution, we would refer to the regional sarcoma center for the patient to have a biopsy of this lesion.
Okay. That's the MR also. What do you see in MR?
So I think I'm just trying to, is these post-contrast images on the left, I think?
Yes, post-contrast.
Yes. So, and then the pre-contrast T1 weighted axial images on the right, and it's showing quite avid enhancement of the lesion, which again is in keeping with suggests an aggressive process. I don't see any evidence on this slices of associated lymphadenopathy. And there's possibly a breach of the cortex of the medial aspect of the mandibular ramus, so the lesion may be arising from there.
Okay. So can you summarize, and what could be your differentials based on your CT and plain radiograph and also MR?
Okay, so to summarize, this patient who has a large right-sided swelling of the jaw has features on the plain film and on the CT of a aggressive periosteal reaction, and this is associated with an avidly enhancing soft tissue mass. So I think this is likely to be a malignant process, such as a sarcoma, but this will require biopsy for confirmation.
What's your differential for this case?
So in terms of other lesions associated with the jaw, you can get things like an ameloblastoma, but it wouldn't have it wouldn't have a soft tissue components like this. And I expect to see kind of a bubbly appearance on the plain film. And I don't think this is arising from any of the teeth. So I don't think this is like it's not a cystic structure, so it's not a dentigerous cyst. I don't think it's arising from a nerve either. It looks like this is arising from the bone, especially because there's a periosteal reaction. So other sarcomas, like the patient's a little bit too old for a Ewing sarcoma, so I think that's less likely. And I don't think this is a metastasis. I've not seen a metastasis to the mandible before.
Okay. Get back to the OPG. So actually, you can see you completely missed this periosteal reaction on the soft tissue here on the right side. So you could have at least compared to the left. So there is nice periosteal reaction. So that's a typical Hundray pattern of periosteal reaction. I don't see any fractures, which you actually mentioned. I'm not seeing any fractures, so we can actually appreciate the cortex well here, and here also cortex, and very nicely outlined cortex. So that Hundray pattern and and a large soft tissue, and in a young 30-year-old patient. So my first differential has to be the osteogenic sarcoma. So this was a case of a biopsy proven gnathic osteogenic sarcoma. And yes, you have to very carefully look for if there is any associated fractures, then if there is any associated calcifications. So, and also carefully evaluate on the left side of the mandible also, and also the central part. So then the CT actually showing haziness of the cortex, and you can nicely appreciate the periosteal reaction and a large soft tissue mass. I couldn't appreciate any bony matrix or mineralization. Then moving on to the MR, this is the post-contrast T1 weighted imaging. You can see kind of a avid enhancement with those periosteal reaction involving the bone marrow, and almost extending into the supra and infratemporal fossa. And yes, there is significant destruction of the angle of the mandible on the right side. Also, going into the heart palate region. So the final diagnosis is gnathic osteogenic sarcoma. All right. Let me. All right. I think for now, I think I've given 3 cases to candidate 1. So if we have time, then I'll come back to candidate 1. For now, we'll go to next candidate, candidate 2. Are you there? Can you unmute yourself? Candidate 2.
Just 1 second. Sam, just 1 second. I think.
Yes, okay.
Candidate 2, can you hear me?
Hello?
Candidate 2, can you hear me?
Yes, doctor, I can hear you. Can you hear me well?
Okay, Sam, over to you.
Yes, okay, sir. This is your case, candidate 2. This patient came with history of jaw pain, and we did CT.
Sorry, history of dropping or
Jaw pain, jaw or
jaw?
facial pain.
Okay, yeah.
So just
scrollable?
request a control. Can you send a request to control so that you can take this case and scroll by yourself?
Okay, I'm trying now. It should be in the view options.
I haven't received.
I can't actually find it. Ask for it. Can you give it to me, the control itself, or should I request it?
Yes. You have to send me a request, then I can approve it, and then you can take over. So I haven't received that request.
I'm trying to find the icon itself, but I don't know. It seems disappear. Okay, so this one.
Candidate 1, are you with us?
Yes, I am.
Can you guide candidate 2 how to ask for the mouse?
I'm trying.
I'm not able to request control either.
I have here the view options, but there is no.
Let me scroll it for you. There is no not issue.
Okay, sorry, doctor.
No issue. Okay, is this okay now? Yeah.
Okay, I'm provided with CT neck of a patient who complains of a jaw pain with IV contrast. I'm scrolling through the whole images, as in I will start to describe the abnormality.
Okay. So now I'm scrolling cranially.
Yeah. So I can see that there is, I will define the large heterogeneous mass with heterogeneous post-contrast enhancement that is seen within, I'm trying to locate the anatomical location of this mass. It seems to be centered upon the parotid triangle. Okay.
Do you want to ask any history? You are free to go. You can ask me any history.
Is this history is long, or maybe this jaw pain, is it chronic or acute pain?
It is started just 2 days ago, and he had a severe fever for past 1 week. But the jaw pain and neck swelling started just 2 days ago.
Can I ask about the patient age?
Age is, I think 50.
50? Okay.
Yes, 50.
Okay. So given the appearance of this heterogeneously enhancing lesion within the superficial lobe of the parotid gland, I can see also that there are multiple enlarged bilateral upper and lower deep cervical lymph nodes. The lower extension of the mass itself appear to be reaching the lower neck. I can see also that there is some sort of stranding of the surrounding fat planes and also edema of the overlying skin. I'm trying to locate any deeper extension of this lesion within the carotid space or the deep lobe of the parotid gland. Yes, there is some sort of extension into the deep lobe of the parotid gland with maybe some sort of attenuation of the carotid sheath content. Okay. Actually, I cannot define the right internal jugular vein on the same side. So
Excellent. Yes, that
maybe
is
it
what
is
I want you to pick in when as soon as you see the scan. Okay, go ahead.
So given the patient history, I'm thinking of underlying inflammatory or infective etiology within the parotid gland, which has been complicated with maybe internal jugular vein thrombosis. I would like to see the pre-contrast also to assess if there is any like obstructive stone, which could be the result of inflammation within the gland with abscess formation. However, given the patient age, I would be thinking also of underlying maybe malignant process with infiltration of the internal jugular vein. So these are the pre-contrast imaging of the same patient. I will try to look for any calcific foci within the ducts of the gland or the gland itself. Okay.
So based on the history and the CT findings, what is your diagnosis and what is your next step?
So as a first possibility, I'm thinking of inflammatory etiology of this lesion due to also the bilaterality of the lymph nodes and the infiltration of the surrounding fat planes and also the overlying skin edema. I would be thinking of parotitis, maybe with impending abscess formation, or it could be maybe a complication of dental surgery or something related to this area, which has been complicated with internal jugular vein thrombosis. So I would like to refer this case for the head and neck surgery and arrange for biopsy for this lesion.
Okay. So yes, candidate 2, you have done well. So there was an initial struggle where you couldn't find out where the epicenter of the lesion is or the pathology is. So let me just get back. Yeah. So this is the plain study. You can actually appreciate the right parotid, especially the deep lobe of parotid is not separately seen. So can you see this? There is some significant fat standing. There is enlargement of the right parotid. Look at the left parotid. So there is definitely some inflammatory changes. Given the acute history, patient had a fever and an URI a week ago, and he still continued to have fever and then suddenly developed neck swelling. Then you should think of a inflammatory or infective etiology first, followed by the malignant or any other mass lesions. So in contrast, let me just show you the findings in contrast. Can you see the right internal jugular vein is not seen at all? See the left internal jugular vein. The internal jugular vein on the right side is not seen as we keep tracing. It's actually from here. You can see here there is nicely it's formed, and then as I keep scrolling up there, so this is completely infiltrated or it's like involved intraluminal predominantly, and you get to see this large abscess kind of cavity, and with the central necrotic or the pus. The deep lobe is not separately seen, so you can see nice heterogeneous enhancement involving the deep lobe, and there are multiple lymph nodes. You can see these lymph nodes here. These are all enlarged lymph nodes here. Some of them are necrotic also with the central non-enhancing area. So this was a classic case of Lemierre syndrome. Have you heard of this, Lemierre?
Yes.
There is a deep lobe of parotid which is like infected, and then which is infiltrating, forming an abscess, and then the abscess has gone into the retromandibular vein, and then from there is a thrombus involving the
Yeah.
internal jugular vein.
So it is
So,
like
do
thick
you?
thrombophlebites, right?
Yes, yes, yes. So there is a small PowerPoint. I just want to show the relationship between the retromandibular vein and the internal jugular vein. There. So that is the IJV. You can actually see it's coursing over the parotid gland, retromandibular vein, and the posterior auricular vein joins to form the IJV. So there is a sheath which is present along the parotid, which is in direct connection with the retromandibular vein. So once the sheath is get infected, and then it slowly encroaches, and the abscess involves the retromandibular vein, and then over the course of time, rapidly it can progress and form a thrombus within the IJV. So in our case, the patient had because the thrombus was quite large, and the abscess, there was quite a large of abscess which was drained. So they did eventually the surgical thrombectomy for this case, involving plus the removal of the part of the internal jugular vein which was completely thrombus. So these thrombosed cases may not respond well to the anticoagulants. So remember these two important causing agents, mostly Staphylococcus aureus. This patient also had this methicillin resistant, and these both grew in the culture. The Fusobacterium was also present. So other treatment options, which includes mechanical thrombectomy, you can do balloon percutaneous thrombectomy, transluminal angioplasty, catheter-directed thrombolysis, provided these treatments can be done only if the thrombus is a very short segment. Unlike in our case, the thrombus was quite large, and it was quite infective. All right, I'll show you the next case for you. Just a second. All right, this is case 2 for you. Should I scroll again, or
Yes, I
how's
was
it?
no, I didn't find it.
Okay, fine. So this patient came with history of trauma.
Okay. I'm provided with sagittal images of the knee joint of a patient post-traumatic stair images. I can see that there is significant amount of joint effusion, which is seen mainly in the suprapatellar recess.
You can ask me to stop if I am scrolling anywhere you want me to stop. I'll do that
just
also.
a little bit slower, just a little bit slower, and if I find anything, I will ask you. Thank you. Okay, I can see a little bit of thickening of the BCL, however, intact fibers. I'm trying to look for, at this image, the lateral meniscus appear normal with no maybe tears or degeneration. So there is thinning of the fibers of the ACL at the intercondylar notch. It may represent maybe partial ACL tear. There is also a fissure or defect within the body of the medial meniscus. I would like to assess if there is any associated bucket handle tear of the medial meniscus, because I thought I saw a fragment or a part of it in the intercondylar fossa. Okay. I think there is a tear of the medial meniscus, and I suspect that there is bony fragment here that's seen beneath the posterior cruciate ligament. I can appreciate also an area of bone marrow edema, which is seen in the most posterior aspect of the medial tibial plateau. So I suspect that this patient is having maybe having a bucket handle tear of the medial meniscus, which I would like to assess it further in maybe a BD fat set, if it is there.
PD fat set. I think this
Yeah.
is PDFS only, the image which you are seeing. This is not still.
Not there is a BD fat set. Okay.
Yes, this is PDFS.
Okay, so giving these findings, there is a
You
little...
want to see the axial and also the coronal?
Yes, please.
I
Yes.
can do it.
Yeah.
There we go.
So I would like to see the axial to assess the patella for any associated patellar injury, and also the patellar reticula. I cannot appreciate the fibers of the ACL here at the intercondylar notch, so I'm wondering if there is like partial tear of the ACL. Here at the axial images, the patella appear intact, also the patellar reticula. I would assess also the collateral ligaments. Which
Okay,
one?
I can.
So the medial collateral
coronal.
ligament. Okay. There is a little bit of extrusion of the medial meniscus, and also there is underlying bone marrow edema within the medial tibial plateau, which could also prove an evidence that there is a meniscal injury at this area. There is a ill-defined high stir signal which seen surrounding both sides of the medial collateral ligament. So I think there is a tear, at least grade 2 of the medial collateral ligament. I'm trying to look for any associated maybe osteochondral defects related to the trauma in this patient, which I cannot appreciate. So there is also a little bit of avulsion, maybe in the lateral tibial spine at this image.
Okay, so based on these, you want to see any other images, or you want to give me a differential for this case, or what do you want to do next?
Can I see the T1? The T1 to
Yes.
exclude underlying fractures or hemoarthrosis within the joint? Okay. I cannot define any hypointense lines in the femur. I'm looking at the tibia, the suspected area at the medial tibial plateau. I think there is no fractures. However, I would also correlate it with any conventional imaging such as X-ray. So given the traumatic history of the patient, there is a tear within the medial meniscus. I think it is a bucket handle tear. And also thinning of the fibers of the ACL, with some of them not reaching the intercondylar notch, so it could represent a partial ACL tear associated with joint effusion. I would like to convey my finding to the referring physician and refer this patient for orthopedic surgery and may need endoscopy for repair of the tear.
Okay. So yeah, you have almost summarized well. Yes, you did pick up that medial meniscal tear, but I wanted you to look at it again. So let me show the findings. So why this case? Why did I put this case? So it's very critical to inform the orthopedic surgeon, especially because you need to do surgery for these cases. So post trauma. Yes. Okay. Zoom it up a little bit nicely, and okay. So can you appreciate the meniscocapsular junction? Can you see this? There is a
yes, there is a little
definite
bit of
disjunction.
separation. Yeah.
Yes, there is a meniscocapsular junction is separated actually. If you look at it very closely, there.
Yeah, I can see it now.
So you have to be very careful and look at it. Yes, you did pick up the complex tear is also involving the menisci. Luckily, it's not extending into the articular surface though. And there is some mild chondral, subchondral changes also. There is some chondral loss here. And yes, apart from that, there is some grade 1 medial collateral ligament injury. Then I assess the, most commonly, these patients will have the ACL tear, but luckily the ACL looks normal, and there is some mild buckling of the PCL though. Other than that, there is moderate joint effusion, which you have already mentioned, and you did look at the patella well, and there is no patellar fracture. I was actually looking for, you asked at the end about the T1. Yes, it's very important to look at T1 if there is any associated fractures. So there are no associated fractures. Yes, on the coronal PDFS, you can actually see there is the medial collateral ligament injury here.
So, doctor, the ACL is intact, the ACL?
Yes, ACL is intact. There is no tear. So that's the PCL here. Can you appreciate on coronal? That's the PCL, and on above, that's the ACL here. That's the fibers. So that looks normal to me, and there was not tear. So usually these cases, meniscocapsular junction disruption usually presents with ACL tear. And then I assess the lateral meniscus or the posterior horn, looks normal. So,
Quadriceps tendon and patellar tendon appear intact.
yes. Yes. All right. So I just want to show a small PPT on, based on the junction. So why it is very critical and important to pick this finding. So that's the meniscal root, and you will get these two ligaments. So that joins and forms the meniscocapsular junction. So that's the posterior most capsule, and that's the meniscocapsular ligament, and this is the meniscotibial ligament. So when you have a disjunction here, which is running all the way up here, so you need to pull this up the menisci and then put a small stitch here, and then you have to attach this along the capsular junction. So that's the procedure usually we do, the orthopedic surgeons, they do. So that's the torn meniscus, especially at the attachment, or the so-called ramp lesion. So this entire thing is called as ramp lesions. So through arthroscopic guidance, so they pull the the ligament that I have just showed you. So they pull this meniscocapsular ligament and meniscotibial ligament, and then they attach it along with the menisci, and then they put a small stitch here. So unless you don't do it, the tear will worsen further, and it is going to extend along the articular surface, and a patient will eventually will hamper his walking. So it is very important to pick this finding and inform the orthopedic surgeon. Okay, let me show you another case. Okay, case 3. This is a very interesting case. Yes, approve.
Okay.
You can scroll. He's a young patient, 22-year-old male, who came with history of right lower limb weakness.
Shall I scroll with up and down, or?
Yes, just give me a second. I think you have, let me adjust the window. Yeah, you can scroll. You can take any window if you want. You can.
I'm just trying to scroll, but it just zooms the image.
Take the next one. You can take, yeah.
This one?
Yes. think you are changing. Let me
No,
do it for you.
okay.
Yeah.
Sorry.
Let me just scroll it for you.
I'm provided with CT axial images of the lung at the medius lung window, or okay.
Look at the just a second. Yeah. Let me do it for you. I'll scroll. Just have a look.
So I'm provided with post-contrast CT images of the brain at the soft tissue window.
Let me scroll it again for you.
I'm trying to localize the area of abnormality. I only just see that maybe there is asymmetry in the vertebral artery on the right side.
Mm-hmm.
I can see the right vertebral artery, but other than this,
That's the angio actually. We did angio. Let me just show you the so yes, scroll.
can you, Doctor, zoom the image a little bit more?
Yeah. So focus on the vessel.
Okay.
Do you see any abnormality? And what do you see?
I feel that the left posterior cerebral artery is not there, but I'm not actually sure about the finding.
Mhm.
Going down to the neck.
So in a young patient who presented with right lower limb weakness, sudden onset,
Okay.
so what do you think?
The window is a little bit bright. Actually, I cannot define any absent non-ossified vessels or.
Should I adjust the contrast?
Yes, please.
Is this okay?
So I can see the posterior cerebral artery is there. Okay.
Look at the vessels very carefully. What do you think?
I cannot define the cavernous portion of the internal carotid artery.
Yes, that's what that's quite a staring at you actually. You see there.
Yeah, I'm expecting to see it at the cavernous sinus, but it seems that like it is markedly attenuated, maybe, or because there is distal filling.
So that's the reconstructed angio. We did an angio reconstruction, so we couldn't. What do you think happening
in the carotid arteries, the internal carotid?
Yes.
You said that the patient is young age, right?
Yes.
So bilateral non-ossification or attenuation of the caliber of the internal carotid artery. I cannot see any collaterals in this angio, so I'm not thinking of maybe Moya disease or like a chronic occlusion. So it must have been an acute setting. So I cannot.
What is your differential for this case? Why is the patient having sudden onset weakness, and then we presented with this sort of angio? What do you think is happening?
Maybe there is embolization, bilateral emboli, maybe from cardiac condition.
We are not seeing any emboli, right?
No.
Okay, fine. I'll just take over this case. So let me explain. So this is the post-contrast cerebral angio was done for this patient. We can actually start to appreciate the basilar artery, and we can see the bilateral V4 segment of vertebral artery. There, let me just go from the basics on base here. Yes, so that's the two vertebral arteries we can actually appreciate. As I keep going up, that's the basilar artery. Note the caliber of all the vessels. So for this age, the caliber is not normal. So there is definitely decrease in caliber of all the vessels, and that's the PCA that we can see. And only the P1 segments are nicely visualized. After that, there is completely lost. And look at these two, the cavernous segments of ICA, how narrow the caliber is. But we are not seeing any swelling defects too. So, and then we can see the horizontal segments, the M1, the M2, and then the distal cortical branches are not visualized actually. If you see on both sides, it's very difficult to visualize the M4 segments or the cortical segments of the middle cerebral artery. And somehow we can appreciate the anterior cerebral artery here. But on an angio, when we did a reconstruction, there is we are not able to actually appreciate the caliber, the expected caliber of the vessels. So this is a case of reversible vasoconstriction syndrome. Have you heard of this? RCVS?
Sorry, doctor, again?
Reversible cerebral vasoconstriction syndrome. So
no,
in a young patient, you should think of this pathology. So the closed differential has to be the primary CNS angiitis. So these two cases, they will usually have these kind of appearance. Young patients who presents with other associated findings that you may encounter in these patients are subarachnoid hemorrhages and stroke-like symptoms. So that's the very typical history. So that's what I was telling you in the descriptor in the history also, patient had short right lower limb weakness. So that's the very typical history they'll give. Do you know any treatment part for these patients? How do you treat primary CNS angiitis and versus reversible vasoconstriction syndrome? Yes,
If
no?
angiitis is part of vasculitis, it could be by steroids, maybe medical treatment.
Yes, yes. So this is very critical and absolutely important to recognize this condition. This was a case of RCS, so these patients will not require steroids. So you can give nimodipine, that's the calcium channel blockers. The patient will recover on its own, on his own for within 3 months of time. However, in primary CNS angiitis, you have to treat those patients aggressively with large corticosteroids and also rituximab. Those are all the immunosuppressive agents that we should give. So this case is very important. So, okay, candidate 2. I think
Thank
I
you.
showed you 3 cases. Yes. We'll move on to candidate 3.
Hello.
And hi, hello.
Yeah, can you hear me?
Yes, yes, I can hear you.
Okay, thank you.
Okay, so this is your case, case 4. You can request for a control. If not, I'll scroll.
I will try to request remote control.
Mm-hmm. Yeah. Just give me 1 minute. Can you just stop? Let me just see whether if this case is correct. Then I'll give you case 4. Yes, correct. Okay. So this patient came with history of headache.
Okay. I have been presented with the brain MRI with a history of headache. I'm now trying to scroll the images.
Let me just 1 second. Let me put the DWA. DWA is here, the subtracted image. Yes. Yeah, this is the DWA.
Okay, I'm now reviewing the DWI images for this patient with history of headache. I cannot see any area of hyper intensity signal in this DWI sequence. However, I can see that there is a well-defined hypointense lesion seen within the right temporal lobe. In my routine practice, I want also to review the other sequence for characterization of this lesion. I cannot see any similar lesion on the left temporal lobe, and also no similar lesion in the rest of the brain parenchyma.
Okay. Have a look at the flare images. That's the T2 flare. Let me just open it for just a second. Let me drag it and pull it up. That's the T2. Yes. Can quickly scroll.
Okay. I have been presented with the axial T2 images. I can see that there is a well-defined hyperintense lesion seen in the right temporal lobe. I can see that this lesion is surrounded by mild edematous changes. I cannot see any loss of salsi-gyri in the right temporal lobe. I want also to quickly review the rest of the sequence. I cannot see any similar lesion in the rest of the brain parenchyma, and I can see that the ventricular system appear normal without any shift of midline structure.
Okay, that's the flare images for you. You can scroll quickly. That's the flare.
Okay, this is a flare sequence for the same patient. I can see that the mass lesion appear hypointense in the flare sequence. And I can see that it is surrounding by mild edematous changes. Can I ask for post-contrast images?
Yes, yes, definitely. Just a second. Yeah. Okay. Yeah, you can scroll. That's the post contrast.
Yeah, this is the post contrast axial images. I'm now going to the region of interest. I can see that this mass region didn't exhibit any contrast enhancement. To summarize my case, I have been presented with brain MRI for an adult patient with history of headache, showed well-defined mass lesion in the right temporal lobe, which appear hyper-intense in T2, hypo-intense in FLAIR, and didn't exhibit any contrast enhancement after giving of IV contrast, and it showed a similar signal to the corresponding CSF. My primary differential diagnosis will be those of arachnoid cyst. Other differential diagnosis, but unlikely it could be due to epidermoid cyst.
Okay. Patient also had some difficulty in vision on the right side.
Okay, so I will review if there is any mass effect caused by this lesion. I can see that there is thickening seen at the medial aspect, the lateral aspect or the posterior aspect, and also the lateral aspect of the right orbital in comparison with the left side. I can see that the optic nerve appear normal and the extraocular muscle, superior extraocular muscle appear normal. I think this is thickening on the lateral rectus muscle. And I can see that there is also enlargement in the right internal carotid artery. There is enlargement of the caliber, and I think there is compression caused by the mass lesion on the orbital apex.
Okay. So what is your differential?
My differential, yeah, it could be these are due to first differential as arachnoid cyst.
Okay, fine. I get this as arachnoid cyst. How about this one? What do you think about this lesion here, which is enhancing homogeneously?
I will give you the remote control because I cannot see your precursor. Where is the lesion?
Here.
Yeah.
Can you see my?
Yeah, now I can see it. Yeah. I think this is thickening seen in the lateral wall of the right orbit.
Will a thickening enhance this avidly?
Yes, it could be due to mass lesion.
So what sort of mass are we talking about?
Extraocular mass lesion with avid enhancement, which does not involve the optic nerve. This rule out meningioma and also rule out glomus tumor.
Glomus tumor here at this point?
No, it's rule out.
Intraocular.
Yeah, unlikely.
What's the top 3 differential for this lesion?
It could be due
enhancement.
Yeah.
Okay.
Evident. Yeah.
Let me just take over. Yeah, it is little bit tricky case. Like you just got carried away by looking at the what do you call the cystic lesion here, which is following CSF fluid signal intensity. That's the arachnoid cyst. But let me just show the DWI. On DWI, there is no diffusion restriction. So this is very important. So this lesion doesn't show any diffusion restriction on DWI. Why I'm thinking? Because an important differential is orbital lymphoma. So in lymphoma, you expect a bit restricted diffusion. Then moving on to the T2 weighted images. So you can actually see, can you see? It's a little bit brighter. It's hyper intense.
Yes.
Can you appreciate?
Yes.
So
yes.
These are all, yes, it's quite hyper intense, and it's something like kind of a clumped up vessel. Can you appreciate? It is not looking like a mass for me. Those vessels are when it's clumped. So T2 hyper intense. Then on flare. So flare also. You see actually those kind of a vessels, actually tortuous vessels which are going across these areas. So that's the T1 next. T1. Okay. Can you appreciate that tortuous vessels?
Yes.
Okay. Then post contrast. Let me show you this is a fiesta or Swiss sequence we call. We can actually appreciate nicely the tortuous vessels and some small T2 hypointense filling defect kind of thing. Can you appreciate? So these are nothing
yes.
but what can you think about now?
It could be due to varix formation of the
Varix
orbital
or T2 hyperintense. You have to think of a slow flow venous malformation. So previously called as cavernous hemangioma. Okay, so the recent updated ISWA states that you should not use the term hemangioma. So this is called. So the final diagnosis for this case is slow flow venous malformation. So other important differential, as I was talking about, is the meningioma. Yes, meningioma will have this sheet-like or plaque-like thickening, but this is these clumped up vessels differentiates from meningioma, and other differential is orbital lymphoma. Varix will have yes, again that's a very close differential. Varix, apart from that, it will have they'll cause proptosis, and the vessels are quite dilated and tortuous compared to the hemangiomas. And these T2 hypointense filling defects are nothing but small calcifications. Okay, so this is about it. Then let's move on to the next case. Case 5. Yeah. Should I scroll it for you, or you can?
I will try to scroll.
Yes. I am giving controls. Patient presented with low backache, chronic low backache.
Okay, I have been presented with T2 lumbar MRI for an adult patient with history of low backache. I will scroll through the images and then I will come back to my finding. I didn't see any obvious abnormality within the lumbar vertebra, apart from dehydrated disc seen at the intervertebral disc space L5 and S1.
Mm-hmm.
I can see that the spinal cord ended at its expected location. So there is no evidence of tether cord.
Mm-hmm.
I can see that the uterus appear bulky and showed multiple hypodense lesion, most likely representing fibroid lesions. Also, I noticed that there is hypointense, well-defined lesion seen in the posterior aspect of S2 vertebral body. Also, this mass lesion cause mass effect or erosion in the posterior aspect of the S2 vertebra and causing like a posterior scalloping. However, this mass lesion does not cause tethering of the terminal terminal nerves at the same level. Also, I cannot see any changes of back wall soft tissue. There is no evidence of spina bifida or meningocele. In my routine practice, I want also to review the axial images and the other sequences.
Take action. Let me just sorry.
Okay, I'm now going down at the area of interest. I don't think it is being covered in this sequence.
Yes. Okay.
Yeah.
Now. So, where do you think the lesion is?
Now, I think the lesion is seen within the spinal canal itself. I think
there is a definition, right? How do you localize a lesion in the spinal cord or within the spinal canal?
Yeah, it could be intraaxial. Intrathecal. Sorry, intrathecal, intradural or extradural. I think this mass lesion is intradural, intrathecal mass lesion, and I think it is also extradural. I think it is extradural mass lesion.
Okay. What do you want to do next? What's your differential for this case?
Differential, I want to see the rest of the sequence and also involving the post contrast for better evaluation.
Interesting. Yeah, that's the post contrast.
This is a sagittal post contrast. I can see that the mass lesion showed homogeneous enhancement in the post contrast images, and also in the axial images, I can see that the mass lesion it looks like it's extending into the left neural foramina, and also cause shifting or the displacing of the spinal cord into the right posterior corner and causing compression. Regarding the neural foramina, I think it's involving the left nerve root and also cause expansion of the nerve exit foramina.
Okay, so your diagnosis and differential diagnosis.
Differential diagnosis because of the homogeneous enhancement. It could be due to the spinal cord meningioma. Other differential, I want to see the T1 image to see if it has a fatty component or not, to rule out lipoma.
So you are contradicting your own statement. So you said meningioma. Will meningioma extend into the nerve roots?
No, the one that extending into the nerve root, it will be the schwannoma.
Okay, so
this could be due to schwannoma lesion. Other differential diagnosis, it could be due to neurofibroma lesion.
Okay, yes. Okay, this is what I actually wanted. Let me take over this case. So part of description is correct. So I can you appreciate these dural tail, which is, can you see this nice tail, kind of tail? You are it's actually within the dura, but extramedullary. That is the terminology that you should use. And second thing, it is not actually extending into the neural foramen. Nothing. It's just displacing the nerve root, just causing a compression. So with the homogeneous enhancement and a dural tail, you should think of a meningioma, spinal sacral meningioma. And an important differential is schwannoma. How do you differentiate? There will be definite infiltration or extending into the nerve roots. But here, actually, it is just displacing the nerve root. It's not infiltrating or extending into the nerve root. And third differential is neurofibromatosis. Yes, NF, that can also have this within the dural space and extramedullary region. And that will also have an heterogeneous enhancement, but this classic dural tail is for the meningioma. So yes, the night on-call resident called this as a normal. So in the morning, when we looked at it, so we could nicely appreciate the lesion. So that's why the initial scans, they just completely missed it. And then in the morning, then when I came back and I told them to do the lower section, so we could pick this up nicely. All right, so I'll just show you next case. Case 18. Okay, so. All right. So this is a 16-year-old female who came with a history of progressive abdominal pain and also a swelling or a lump in the left lower abdomen.
Okay, I have been presented with multiple ultrasound images for the lower abdomen. I can see the urinary bladder, and I can see that there is mass lesion seen adjacent to the urinary bladder, which measures 3.9 by 2.8 centimeter. And this mass lesion appear heterogeneous in ultrasound. And I think the first image is uterus, because this is a female patient. And there is a measurement of the lesion, which could seen in the cavity of the uterus, which appear hyperechoic in this ultrasound. I can see in this image that there is area of hypoechoic seen at the peripheral of this mass lesion. This could be a gestational sac. So in my routine practice, I will ask to do a beta HCG test to rule out if there is any history of pregnancy or not. If it is positive, because this sac is seen outside the uterine cavity, I will think about ectopic pregnancy.
Beta HCG is negative, and also pregnancy test is also negative.
Okay, so other differential diagnosis, this lesion, it could be representing ovarian torsion. If the patient is still in the ultrasound, I will do color Doppler for this mass lesion, and I will also try to look for the left ovary for comparison.
Okay. Let me show you. Yeah, that's the CT. You can scroll.
This is a CT scan for the same patient. I can see that there is oral contrast was given. In the pelvis, I can see that there is a large, well-defined mass lesion that showed area of hypo density. In my routine practice, I will measure the house field unit of this area. I think it will be minus, representing fat, and also I can see calcification foci seen adjacent to the fatty area. This could represent Rokitansky calcified foci. So my differential diagnosis for this is a large dermoid lesion arising from the left ovary. In my routine practice, I will check the rest of the images to see if there is any evidence of fat elsewhere to rule out rupture dermoid. I cannot appreciate any, although in my routine practice also I will change the window for better evaluation of fat lobules. Also, I noticed through my scrolling that there is area in the small bowel which could represent telescoping of small bowel, and it could represent incidental finding of intussusception. Yes.
So your final diagnosis is?
Yeah, pelvic dermoid cyst.
Pelvic dermoid cyst.
Yeah.
So why are you saying dermoid cyst?
Because of the fatty component and calcified foci, and because this is a female patient and young in age and presented with abdominal pain.
What is your differential for this case? How about what other differentials can you think of apart from dermoid?
It could be due to torsion of the dermoid. Other differential diagnosis, it could be torsion of the ovarian itself, the torsion of the ovary.
Okay. How about teratoma?
Yeah, it could be possible because also teratoma containing fat lesion, yes, and calcification, yeah, it could be.
Yeah. So look at the calcification. Let me take over this case. Have a look at this calcification. Is it just within the fatty component? Can you see this?
Yes.
Yeah. So I have just a small PowerPoint. I'll get back to this case again. Let me just show you a small PPT. So it's very important to differentiate between mature versus immature teratoma. So our case was an immature teratoma. So so immature teratoma is much less common when we compare to the mature teratoma. So incidence like in our case, so mostly in the second decade of life. So large lesion at the time of presentation. Usually this carries worse prognosis and malignant transformation, especially because of the immature or embryonic tissue. So it can be associated with mature teratoma when treated. So it can cause the retroconversion. So this is what happened in our case. So it was there was a retroconversion. Immature teratoma usually will have these kind of dispersed fat and also scattered calcifications. But mature teratoma will have that That's the so immature teratomas will have this cyst predominantly will have this attenuation and signal intensity similar to that of a simple fluid, and mature cystic teratoma will have this sebaceous or a fatty component. So calcifications are small, irregular, and scattered throughout the tumor. This is very important in immature teratoma. So you can actually appreciate these small, tiny speck of calcifications here, and also these are all nothing but fatty components. So it should be quite heterogeneous. Whereas in mature cystic teratoma, they are typically coarse or tooth-like and located within the mural nodule. So So if you see a ovarian mass in a young patient, if there is a raised alpha fetoprotein, think of a York sac tumor. If it is a raised LDH, think of dysgerminoma. And if the patient with ovarian mass and virilizing effect, think of a Sertoli Leydig cell tumor. And if it is raised beta HCG, of course, you have to rule out pregnancy. And also, next is you have to think of a choriocarcinoma. And if it's an older woman, post-menopausal bleeding, it should be, if the inhibin is positive, then it has to be a granulosa theca cell tumor. Or if the inhibin is negative in a post-menopausal bleeding, then think of a fibrothecoma. So in our case, this is it's very rare actually. So it is a mature teratoma which has gone into a reconversion. So that typical tooth-like appearance, which is located within the mural nodule, this is what we get to see in our case. Let me get back to that case. Okay, so you can actually appreciate that a small mural nodule, fatty component, and tooth-like calcification. So mature teratomas are very rare in young patients. So this is nothing but a case of reconversion. All right. So let me. Okay, I'll go to candidate 4.
Thank you, sir.
Can
Thank you.
unmute. Yes, thank you. Candidate 4, can you unmute?
Hello.
Hi. Let me show you a case. Case number 6. Okay. Should I scroll or?
I'll ask for remote control.
Yes, please.
Should I start?
Yes, I'll first give you a DWA sequence. Just 1 second.
Okay.
This is the DW. Okay. So history is withheld.
Sorry, again?
History is withheld. I'll you just scroll the case. I'll share the history.
Okay. I'm presented with DWI, axial brain MRI. I'll scroll through the images, then comment about my findings. I think there is some increased signal at the cortex here, but it's due to artifact. In my routine practice, I would window the image. Other than that, I'm suspecting some increased signal with loss of volume of both caudate head. Caudate head bilaterally.
Let me adjust the contrast for you. Wait.
Okay.
It's a little bit. Okay. Can scroll now.
Okay, I'll scroll from down up. So apart from my suspicion about caudate head atrophy, there is mild hyper enhancement with cortical thickening involving the left frontal inferior aspect of left frontal lobe and left insular cortex. Other than that,
have a look at it very carefully.
okay.
You just scroll past the finding.
I'm sorry. Is there like restricted diffusion at
Yes,
the
yes. Let me just
yeah?
yes.
There.
What do you see?
Okay, there is area of restricted diffusion at posterior or let's say medial aspect of left middle cerebellar peduncle, abutting the roof of the fourth ventricle. I'd like to confirm the restricted diffusion on ADC and review the T2 and the flare of the same lesion, if available.
Yes, yes.
Okay, this confirms restricted diffusion of the lesion at left middle cerebellar peduncle. Should I scroll to check if there is any other areas of restricted diffusion?
Yes, you can have a look at the flare and also other sequences if you want.
Flare. Is it here? I'm sorry. I think I don't. I'm sorry. I think I missed the window.
Yeah, just let me take you. Yeah.
Thank you. So this is axial flare MRI of the brain.
Why are we seeing flare images, especially in cases of stroke? Do you think there is any added value?
Yes, well, flare is very sensitive first to any white matter abnormality, especially in the supratentorial region.
No, I'm talking about in cases of stroke.
Stroke?
Yes, why flare is important? What is DWI flare mismatch? Have you heard of that?
Okay, yes, DWI flare mismatch.
What does it signify?
No, that's the
no problem. You just scroll and see if there is any.
I'll scroll first through the images. So there is abnormal signal at central horns as well as the abnormal signal at left cerebellar, middle cerebellar peduncle.
So this patient, I'll give you the clinical history now. Patient had that classic conjugate palsy and also facial nerve palsy. So where do you think, can you precisely localize that area and what is happening? Which area is involved?
Okay, conjugate palsy and, sorry, again, what is the other thing?
Facial nerve palsy.
Facial nerve palsy. So it could be in the facial
What
nerve.
is that strategic location called as? What is that? This is going to test your anatomy though. This is a very straightforward case. So full marks if you give me the anatomical localization.
It could be
and that is a very typical history. This is a very typical history.
Well, it is lower than the inferior colliculus. We are at the level. and
Mm-hmm.
so lateral, no, the lateral geniculate is higher also. I'm thinking, well, the facial nerve nucleus is located in the pons, but the
How about
conjugate,
the abducent nucleus?
the
Where is it
abducent,
localized?
it is in the pons. The abducent arises from the pons
Yes,
at the
yes,
anterior
yes.
medial aspect also.
Mm-hmm. Okay. Yeah. So let me take over this case. It's a
Yes.
very interesting case actually, and like I say, this is going to test your anatomy. If you get it full marks for you. So this area is nothing but the tegmentum of pons, and the classic history which I said was nothing but facial collicular syndrome. So patient had the typical conjugate palsy that is involving the abducent nerve and also the facial nerve. So these two are very critically arising and traversing through this pons. So it's a facial collicular syndrome. So please read about it. And in the exam, localizing it precisely will definitely fetch you a very good marks or higher marks. So remember that. And you should be very thorough in localizing infarcts. So don't miss out on these syndromic infarcts. Okay, let me show you next case. Next case is also a very interesting case. Case number, just give me a 9A. Yes. Yeah. Patient had a ventriculoperitoneal shunt. I'll just give you a history. But presented to us repeated headache and vomiting. So we did MR. Should I scroll it for you, or you want to?
No, I can scroll. Thank you.
Yes, yes. Yes.
I'm presented with axial DWI of the brain. This shows marked dilatation of both lateral ventricles with dependent restricted diffusion at occipital horns of both lateral ventricles, and also extending into the right temporal horn. I'm checking the fourth and third ventricles. Well, the third ventricle is also dilated. The fourth ventricle is mildly dilated, but to lesser degree than the lateral and third ventricle. There is also dependent restricted diffusion in the third ventricle.
Okay.
You told me the patient has a VP shunt. There is also area, I think, of encephalomalacia, maybe related to previous cerebromalacia, with porencephaly, maybe related to previous intervention or trauma, or if perinatal insult.
Okay. You want to see the ADC? Let me just put the ADC for you. Okay.
So the ADC confirms diffusion restriction in the dependent content in the lateral and third ventricle. Also, it shows a kind of T2 shine through of hyperintense signal in the periventricular area, indicating active subependymal flow. So if this is the before, like the VB shunt is not working, obviously the ventricles are dilated. So this is active hydrocephalus. I'm suspecting extradural collection here at the right cerebral convexity, but I would like to check it on other sequences if available.
Yeah. Yes. This is the T2.
Okay.
Can scroll through.
So this is axial T2 of the brain of the same patient. There is hypointense dependent signal in the ventricles, and also extraaxial likely subdural fluid collection with abnormal signal involving the uppermost aspect of the right cerebral hemisphere in the loss of gray-white matter differentiation. Okay, the VP shunt is entering from the left side.
Okay. Want to see any other images? Let me show you a flare.
Okay. So there is white matter edema in the flare and dependent content that is not suppressing in the ventricles. And the extra axial fluid also didn't suppress, so I'm suspecting extra-axial hematoma at the right cerebral convexity, in addition to intraventricular, well, my top differential is intraventricular hemorrhage, but other possibility if the patient presented acutely with fever would be like intraventricular bus, but maybe I will check the T1 and T1 post-contrast. Okay, this is T1 without IV contrast. Also, there is evidence of previous like surgical intervention or maybe craniotomy. If it was in urgent situation, maybe it was for decompression. If the patient has raised intracranial pressure or it's long-standing, I would check patient's previous images. So the intraventricular content are hyperintense on T1, so favoring blood. There is no tonsillar herniation. Sorry.
Okay, let me show you a contrast, post-contrast. We have done a contrast also.
Okay.
Let me just see if this is the correct sequence. Just a minute, let me show you the correct sequence. Yeah.
Yes.
You can scroll.
Okay. So there is ependymal enhancement of posterior aspect of both lateral ventricles.
So what is your final diagnosis?
There is also enhancement of the what I presume that it is a parenchyphalic cyst. So I'm suspecting acute ventriculitis. Is there here something? There is something here that is hyperintense. It might be enhancing at the right occipital lobe. Well,
okay.
I'm suspecting acute ventriculitis with as a cause of the hydroceph, which would be in this case obstructive hydrocephalus, and that caused the VP shunt malfunction and acutely raised intracranial pressure. Maybe the acute intervention was the craniotomy for decompression of the intracranial pressure that resulted in the subdural hemorrhage. But the intraaxial here, the enhancing area, could it be like extension of the infection cerebritis? I'm not sure. I didn't.
So what will you assess next? How will you take this case forward? What will you do next? And
I will urgently contact the treating physician to check the patient's condition. If the patient presented acutely in fever and has signs of infection, and meningism maybe, so my top differential would be ventriculitis with Okay, and so after
Okay,
fixing
you diagnosed him with ventriculitis. What will
okay,
you do next?
urgent
What other?
neurosurgical referral for
Okay,
replacing the Viva shunt, and
Mhm.
maybe after lowering the intracranial pressure, LP can be
Mhm.
done, but before that, it would be dangerous for the risk of herniation.
Okay.
LP can confirm the infection, and IV
Mhm.
antibiotics, of course.
Okay, so the answer actually I was expecting was next is to see whether the shunt is being placed correctly or not, and is there any problem with the shunt. So as I narrated the clinical history, patient had. Let me get back to this case again. I'll
Yes.
show you. We have done a CT. Have a look at the CT. Okay, you can scroll through.
This is abdomen CT scan without IV contrast. And it's not scrolling. Oh, scrolling slowly. Okay, let me move it from up. Maybe it would be faster.
Or let me just put the thin slices. Right.
Well, I stopped using the mouse, but it's like delayed in scrolling. That's why.
Okay. Right. Put a thin section. Yeah. So let me take over this case. So it's a very interesting case actually. So patient had a repeated ventriculitis in a span of just 2 months time. Patient kept having frequent hospitalization. Can you see this? The shunt tip. So the peritoneal shunt is just pierced within the cecum actually, and the tip is actually within the cecum. Can you see?
Yes.
So this is throwing multiple infections or ventriculitis picture. So it's very important. You always assess the where the tip is. Let me get back to that case MRI. Yes, you did pick up all the findings very well. So I'll start from the ADC. So you can actually see nice appendageal diffusion restriction. Can you see these layering there? So these are all nothing but active infection. So there is severe inflammation of the ventricle along the appendages of the ventricle, and the post contrast we just saw confirms nice enhancement actually along the appendages. So let me show the post contrast. We just opened. Just a second. Yeah. Can you appreciate the enhancement very nicely? You can all appreciate the enhancement, and these are all nothing but layering or infective cross points which is within the ventricles, and there is quite a ventriculomegaly. The other thing that you have described, there was something here. There was enhancing actually. So those are nothing but appendageal enhancement and also inflammation extending into the adjacent brain parenchyma. So they rapidly, the neurosurgeon decompressed this, was put on antibiotics, and then they repositioned the tip which is in the peritoneal tip, they have repositioned. So patient recovered well. I think she's here to come for follow-up for the next scan. Okay, so I'll show you another case. Case number 8.
Okay, so I'm presented with chest X-ray, a frontal chest X-ray, or is it a scanogram of a skeletally mature
X-ray.
X-ray, okay, of a skeletally mature patient. I can see multiple lines overlying the chest, so the patient is likely acutely ill.
Sorry. Okay.
Okay, so on my first inspection, there is a bilateral peripheral fluffy hyper opacification of both lung fields, mainly at mid and lower zone, however, sparing the CP angle and most superior aspect or lung apices. This gives the reverse batwing appearance or the negative pulmonary edema. So I'm thinking about hypersensitivity pneumonitis. I'm checking the rest of the scan.
Patient is having dry cough.
Dry cough. Okay. Is there a cavitary? I'm suspecting a cavitary lesion with thick wall at the left mid lung zone.
And his CD4 count is 300.
Dry cough, CD4 count 300. So the patient is immunocompromised. So bilateral fluffy opacities and in ground glass mid distribution. I would think about PCP, but I'm checking if there is, other than the cavitary lesion at left mid lung, I can't appreciate actually any lung cysts. I'm checking the bone.
What are the differences can you think of with this immunocompromised patient and dry cough? And you mentioned as the fluffy space opacity.
Well, I can think angioinvasive aspergillosis. Bronchial bronchial lavage.
Just be very careful with your words. You said CT guided biopsy. Don't throw away your
not
this
CT
one. Yeah.
After doing the CT, maybe biopsy would be considered, but because I'm thinking what would happen at the
having him. Yes, immunocompromised patient and with CD4 count is less, and you get to see these fluffy space opacities, and you are saying CT guided biopsy is not the correct approach. Yeah, okay, go ahead. What else you will do?
Okay, so CT scan would be the first thing.
Okay, fine. So we did CT also.
Okay.
Yeah, can scroll.
Okay. So this is axial CT scan of the lungs in lung window. There are bilateral ground glass opacification.
There's a specific terminology for this pattern. What is that pattern called?
Well, with interlobular septal thickening, I'm thinking about crazy babying pattern.
Yes. Okay. So
I'm checking if there are few air cysts, but they are so one at the left lower lobe. No other cystic lesions. And there is right-sided pleural effusion. Both hila seem bulky, but in my routine practice, I would check for lymphadenopathy at the mediastinal window. There is some consolidation at medial segment of right middle lobe as well. So in such immunocompromised patient and bilateral crazy waving pattern, I would be thinking about pulmonary alveolar proteinosis. And also
pulmonary alveolar proteinosis.
Yes. And also differential diagnosis, also PCP, pneumonia. I didn't see any cavitary lesions or to suggest angioinvasive.
What other findings you will see in pulmonary alveolar proteinosis?
Pulmonary, it would have a crazy waving pattern. And
only crazy paving pattern?
No, it would be mainly peripheral and lower lobe predominant.
Remember, in exam, actually, the examiner will not guide you, and even if the examiner guides you, your score is going to get lower. And don't take any much clues from the examiner. And most of the examiners will not speak in the exam. So, me being a good examiner, I'm just pushing you towards the case, giving you all the history. But don't expect that in the exam. And be very cautious when you are placing your differential diagnosis 1, 2, or any other findings that you see in pulmonary alveolar proteinosis. This is actually a very simple case, and you are just missing it out. You have started everything correctly. Are you there? Candidate 4?
Hello? I'm sorry.
Yes.
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 Yeah. So.
No problem. So your final, can you sum it up on your, so you said your first.
I'm thinking about opportunistic infection in an immunocompromised patient. So this would include PCP, would include atypical infections like fungal, but I can't see any like cavities or something to suggest a specific one. Also, cytom CMV, but would be unlikely to be able to present like this.
Okay, fine. Let me take over. I'll explain the radiograph first. So yeah, you explained actually very well. These are nothing but fluffy airspace opacities, and there is no set pattern. It is just diffuse and predominantly at the perihilar region, and I'm not seeing any pleural effusion though. So the CT angles are clear, but the right heart border is quite hazy, and it's not very well defined. So moving on to so my differential in this case with the immunocompromised, I would first definitely think of a pneumocystis jirovecii pneumonia, and the PAP is pulmonary alveolar proteinosis is very less likely. It will also have these calcifications. This is what I was expecting. PAP will present with calcifications and of course crazy paving pattern. My second differential based on this has to be the angioinvasive aspergillosis. So these are my two top differential based on the radiograph. So moving on to the CT chest. So yes, we can nicely appreciate the fluffy airspace opacity. You can actually see predominantly scattered in the lower lobes or the lingular segments. And as I scroll cranially up, I can actually appreciate the classic, these are nothing but interstitial interlobular septal thickening or the crazy paving pattern. So, and scrolling down, So you can nicely see some developing consolidations are also happening here. So here, the left lower lobe. So with a fever and patient is having dry cough and CD4 count of less than 300, and with all this imaging findings, I would definitely think of a pneumocystis chirorrhea pneumonia, and then followed by the aspergillosis. So aspergillosis I can easily rule out, except for the fluffy space opacity. These crazy paving pattern will not be very classic in the aspergillosis. Okay, I just want to show a small slide on this PCP pneumonia. Yeah. So it can be seen in both HIV positive or immunocompromised patients or non-immunocompromised patients. So if you get to see in non-immunocompromised patients, you'll have this classic ground glass opacity, which is predominantly in the lower lobe, and you'll have this consolidation, which they develop rapidly in non-HIV patients, and it can progress to ARDS. So solitary or multiple lung nodules, it can mimic granulomatous inflammation, and cysts are rare if present. If at all you get to see a cyst, it is most common in the upper lobes. Moving on to the in the immunocompromised patients, so you will have this very typical finding and atypical finding. Typical, the ground glass opacities are more common in both typical and atypical. In typical, you will have the central distribution with peripheral sparing. That is what our case is. But there is developing consolidation. We saw septal lines and crazy paving pattern. And you'll also get to see variable sized pulmonary cysts. There was one small cyst, I'm not sure if you have noticed, which is developing in the left lower lobe. In atypical findings, there will be perihilar and apices with subpleural sparing. There will be mosaic attenuation, architectural distortion, and there will be progressive increase in density of the infiltrate. So a very important teaching point is in non-immunocompromised patients, it can rapidly progress to ARDS, whereas in immunocompromised patients, it goes, it's a progressive increase in infiltrate. All right, thank you. I think we have exceeded our time also. Let me hide the floating controls. Thank you, candidate 4. I think all of you have done well. So remember in the exam, be precise, especially when you are mentioning your differential diagnosis. It has to be the most relevant to the least relevant. I wish you all the best for your exam, upcoming September session. I'll hand over to Sir. Sir, are you available? Yes, sir.
Sam, thank you very much. A brilliant session. I was partially looking and partially working, so I could not follow all cases, but some of the cases I did see, they were brilliant. Sam, can you hear me?
Yes, sir, I can hear you.
Right. So, that's great. Because I was not attentive in the last few minutes, Sam, anything for me, or that is it? Have you finished, or?
Yes, sir, yes. Completed. I think I have taken some 20 minutes extra.
That is absolutely fine. It's gold for everybody. They should
Mm.
be, more than happy, because the more the better. So that is absolutely brilliant. So announcement for next week. I'll just announce on Instagram, and you'll get an email. We have got a new teacher for next session. He's joining the faculty for the first time. So tune up for next session, which will be taken by a new faculty member. I'll come back to that, but on this weekend, there is a pre-recorded session from Basildon A to Z course, rapid reporting lower limb. And this was conducted by Dr. Bhavan Upade he's a consultant in Royal National Orthopedic Hospital. So it's sort of a teaching type of a format for lower limb. So don't miss that. That is rapid reporting. And I think he will show one or two mock exams also. The same series, upper limb, will be conducted on the next weekend. I'll upload this schedule also. So next Thursday is as I've told you, a new faculty member, and he is